for this very important message.
I would like to introduce Ahmed Gawesh, Alexandra University Consultant, Vice President of EAVCA. The topic is, when should we decide removing a pulmonary embolus is needed?
Thank you for the kind introduction, Elena. Ladies and gentlemen, it's a great honor and pleasure to be invited to speak in the 17th chapter of the Egyptian Vascular Club. And our talk would be about when should we decide removing a pulmonary embolus is necessary. I have no conflict of interest related to this presentation. And I would start with a case presentation. We were notified to see a British lady, 60 years old. She had recent transabdominal hysterectomy, and in post-operative day 4, she developed shortness of breath and hypoxia. Her oxygen saturation dropped to 82 to 90% with oxygen mask, and on examining the patient, she had bilateral lower limb pitting edema. Actually, we were notified that she was stable hemodynamically. However, she was tachycardic with 120 beats per minute as a pulse rate. So while the ICU doctor was calling me, actually I asked him 2 questions. Did you do an echocardiography, and did you do cardiac enzymes for this patient? And this is a workflow I want to highlight, that it's very important to stratify patients with pulmonary embolism, as we will see later on. So when he notified me, I took my car and went to the hospital, and luckily, she was doing the echo, and the echo showed severe right ventricular strain, and the cardiac enzymes came out shootingly high with pro-BNP more than 10,000. So a diagnosis of submassive PE was done, and she with severe right ventricular strain and shooting cardiac enzymes. So the next step was to do a CT pulmonary angio, which showed that both pulmonary trunks were studded with clots, as we see in the angio. So our decision was, we discussed the decision with the husband, the pros and cons of intervention, because we discussed that we would use a mechanical thrombectomy device, which is the penumbra. We took the patient to the cath lab, and as you can see, both pulmonary trunks were obstructed, and we were able to retrieve some clots with the penumbra, and these were the images after the intervention. And you can see on table improvement where her oxygen saturation jumped to 97% on table. So, and she was discharged 2 days after that in the hospital, from the hospital, happy and healthy. So we know that anticoagulation works with most patients with PE, but not all patients having pulmonary embolism behave in the same manner. Although the majority can have low mortality with anticoagulation, still you have an escalating severity and mortality risk with the intermediate risk and high risk PE. So it seems justified to escalate the method of treatment according to the increased severity and mortality. Not only rely on anticoagulation. So if anticoagulation is suitable for the majority of patients with low-risk PE, we still need the TPA, for example, systemic thrombolysis for patients with massive PE, that's no doubt, and studies have shown that you can significantly reduce mortality by using systemic thrombolysis in massive PE. But what about the gray zone in between? The patients who are not having hemodynamic instability, but still they are not the so-called mild PE. And this area is the intermediate risk PE, which we have to focus on. We should stratify our patients not only on hemodynamic stability, either massive or non-massive, but there is the intermediate risk PE, which should be classified according to the presence or absence of right ventricular dilatation, the presence or absence of elevated cardiac enzymes, and also the simplified PESI score that actually looks into the blood pressure as well as the pulse taken into consideration. So the American Heart Association and the European Society of Cardiology actually provided this classification, And the essence of it is that patients with intermediate risk PE are at risk of decompensation and higher mortality, because the right ventricular strain is a marker actually for that this heart might fail. And when it fails, the patient would go into an obstructive shock, which increases the risk of mortality. So it's a marker you have to see with the echo. And not only about the acute mortality that matters, actually studies have shown that long-term PE sequelae, which we call post-PE syndrome, those patients from the pulmonary obstructive, the residual pulmonary obstruction from the post-thrombotic changes in the lower limb, we have the patients usually suffer from persistent dyspnea and impaired quality of life. So it's about also the long-term PE sequelae in those patients. This study was published in 2020, but it has many fallacies. However, they looked into the long-term mortality following these patients for 5 years. They found that intermediate risk PE can lead to increased mortality reaching 40% in 5 years. So besides having a disastrous effect on the acute mortality, it can have long-term sequelae as well as increase the long-term mortality. So are we justified to use systemic thrombolysis to extend the indication beyond the massive PE to those patients with intermediate risk PE? That was the question of the PYTHO study, which compared the two arms of patients with intermediate risk PE given systemic thrombolysis versus anticoagulation. And actually, the PYTHO study was the cornerstone, published in 2014. It was the cornerstone of all the advances made in this area afterwards, because it was able to show that you can halve the mortality with systemic thrombolysis. However, on the expense of increasing the risk of bleeding, because major bleeding actually is 6.3% in the systemic thrombolysis group versus 1.2%, which was statistically significant. So the PYTHO study provided the proof of concept that yes, mortality can decrease if you decrease the clot burden, but we need better tools. And that's why we have many toys around in the market now. The ECOS catheter, besides catheter-directed thrombolysis, and the AlphaVac, the AngioVac, all these clot removal instruments are actually evolving and progressing, and they are showing good results. And every product out in the market have done its studies, and it shows that it works, but still we don't know for which exact patient we should resort to catheter-directed thrombectomy devices. There are currently many randomized controlled trials. Most outstanding is the high PYTHO. We are waiting for the results, but the small studies are actually having encouraging results so far. But anyways, whether you have a PER team, as they advise worldwide, to have a pulmonary embolism response team where you pick these patients early on, because intervention earlier is better. But if you don't have in your hospital or institute a PER team, at least have an algorithm in your mind when you are notified about patients. Don't think about, as Dr. Assam Al-Adi said, not only thinking about putting a filter in. You have to be very cautious in selecting which patient would need a filter. Just the last line. So, because there is something to be done for a group of patients, so at least do stratify your patients with an echo and cardiac enzymes before you decide whether you would intervene or not. And finally, my take-home message, anticoagulation remains and will remain the mainstay of treatment in patients with acute PE. Clot removal can help. Selected patients can benefit from clot removal strategy, especially those with intermediate risk PE that can progress to hemodynamic instability. Patient selection is key for success, and also there are lots of randomized controlled trials currently ongoing. We're waiting for super selection of which patient would benefit most. And finally, still, the risks of intervention as well as costs has to be taken into consideration. So let's hope for a better future, and thank you.
Thank you, Dr.